Hello, everyone. I'd like to begin by acknowledging the traditional custodians of the land on which we meet. I pay my respects to their elders, past, present, and emerging. And we'd like to extend that respect to other Aboriginal and Torres Strait Islander people with us today. So welcome all the delegates to the 2021 UN and Australia Sustainable Partnerships Forum. My name's Barbara McPake, and I'm the Director of the Nossal Institute for Global Health, Melbourne School of Population and Global Health, and I'll be your host for today's session. Before I introduce our speakers, I want to encourage all our delegates, please, to use the chat feature. It's located on the right-hand side of your screen. Use it to comment, share similar work or research, add thoughts. But if you want to raise something for the discussion after the presentations, best to use the Q&A page or simply raise your virtual hand, and we'll bring you into the session with video and audio when appropriate. So don't write your questions in the chat feature, but do write comments and so on that you are not wanting to share visually or orally. If you need to contact our events team or tech support, navigate to your inbox at the top of your screen and search event support for instant chat. So I'd now like to introduce the speakers. Please welcome Professor Marion Saville, AM, and Executive Director of the VCS Foundation. Professor Susan Sawyer, AM, MBBS MD, FRACP. And Professor Tony Capon, Director of the Monash Sustainable Development Institute. Welcome, everyone, and thank you for being part of this discussion today. So first, we're going to hear from Professor Marion Saville, AM. She's held the position of Executive Director of the VCS Foundation Limited since 2000. Marion has served on cervical cancer screening advisory committees in Australia, New Zealand, and Ontario, and chaired the working group to review Australia's guidelines for the management of screen-detected abnormalities in the National Cervical Cancer Screening Programme. Marion is focused on research and implementation projects demonstrating that it's possible to deliver high-quality, acceptable cervical screening in a range of resource-poor settings, including Malaysia, PNG, and Samoa. She's also interested in how culturally safe screening can meet the needs of disadvantaged groups who have poorer cancer outcomes in Australia and New Zealand. Welcome, Marion.
Thank you very much, and Barbara, and thank you for the organisers for inviting me. And I feel privileged to be speaking to a group of people interested in global health. And I'm aware that for a lot of you, cervical cancer isn't high on your list of global health problems. It's a cancer that's caused by a chronic infection with a virus, the human papillomavirus. And if you're not aware that it's a major global health problem, or you haven't been touched by someone in your life, then you probably live in a high-income country and you're probably not particularly disadvantaged or marginalised. This is a cancer that's been preventable for decades through screening, and for the past decade we've added vaccination to our tools to prevent this cancer. Screening is a tool for today's generation of women. Vaccination of our adolescent girls will be important for future women, but it is not enough to solve the slow-moving pandemic we have and the increase of cases amongst mid-adult women. A lack of access to screening over decades has led to incredible inequity, both within Australia, but also within our region and globally. Low and middle income countries in our region are losing women in their 40s and 50s, so there's a gender equity lens here. This cancer leaves behind children who are then vulnerable, and even if women don't die of this cancer, the diagnosis of the cancer and the treatment, even in middle income countries, is frequently financially catastrophic for families. So in response to this, and knowing that we have the tools to prevent this cancer, the WHO has endorsed a strategy to move towards elimination of this cancer as a public health problem by the end of the century. And the three pillars of that strategy are to vaccinate 90% of age-eligible girls, to screen 70% of the world's mid-adult women at least twice with a high-quality test such as an HPV test, and to afford dignity and humane treatment to those women with cancer that we can't prevent or treat. So we have to focus on access to screening. And I spent 20 years running one of Australia's biggest pap smear labs. And for those of you who are not particularly medical and not particularly, I'm going to have to, aware of this situation, haven't had a pap smear taken, this is the problem. This is the speculum. Lots of women don't like it. It's culturally unacceptable for many women to have this intimate exam, and it's physically uncomfortable for many women. Traumatised women find it very difficult to be that vulnerable. The big breakthrough we've had is the availability of good quality HPV tests, and with those we can get a result that's just as accurate with a swab like this that a woman can take herself. And in our studies, it's highly acceptable in a range of cultural settings. Women have embraced it and described it as empowering and dignified. So this is a great breakthrough for here in Australia to reach communities we can't reach at the moment and in the region. Also, if we want to test 70% of the world's mid-adult women, that's billions of tests, the speculum's not scalable. You need a health worker very highly trained to put that in and locate the cervix. This is very scalable, and then we can have our health workers concentrate on the 10% or so of women who have HPV. Cervix cancer is a slow-moving pandemic, and if we keep doing what we're doing now, we'll go from about 250,000 deaths a year to about 1 million deaths a year. But the WHO strategy can avert 50 million deaths over the next 50 years. There are a range of partnership and collaboration opportunities emerging. I was really pleased to see the session on partnership this morning, and a lot of it rang very true for the work we're doing. I'm pleased to say that the Minderoo Foundation has made a significant donation to a consortium of partners from Papua New Guinea, Vanuatu and Australia to catalyse a program of work to show that we can reach those targets in women in their region. The pandemic has slowed things down, but there are opportunities. The pandemic has expanded our capacity to do the PCR test for the presence of the virus. It's the same technology that we use for HPV. It has also normalised direct-to-participant messaging of results, which is a strategy we use in our projects to make sure that screened women who have positive results are followed up effectively. So I'd urge you to think about cervix cancer as a canary in the coal mine when it comes to many of the Sustainable Development Goals. If we can get these services to women throughout the world in the poorest resource settings, we will be strengthening healthcare systems in doing that. And hopefully we've got a brighter future for women across the world. So I'll leave it there, Barbara.
Thank you, Marion. So we'll now hear from Professor Susan Sawyer. She holds the Jeff and Helen Hanbury Chair of Adolescent Health at the University of Melbourne and is Director of the Centre for Adolescent Health at the Royal Children's Hospital, which is a World Health Organization collaborating centre. A paediatrician by training, Susan's efforts have helped to extend global understandings of the importance of adolescents and their health and well-being in Australia and globally. She's developed a suite of educational initiatives to close the global learning gap, including a massive open online course in global adolescent health. Susan is president of the International Association for Adolescent Health. She's held numerous advisory roles for the World Health Organization and is the inaugural co-chair of an Australian network of WHO collaborating centres. Welcome, Susan.
Thanks, Barbara, and good afternoon to you all. And this is a really lovely opportunity. I'm excited to be speaking to you about the importance of adolescents within global health. Certainly when I was a medical student at the University of Melbourne, adolescence was completely neglected. And I confess, even as a paediatrician, adolescence, I think, was framed as, back then, a very brief period of turmoil to be got through. And certainly that's consistent with the neglect of adolescents within the MDGs, notwithstanding the relevance to many of those targets. But in the lead up to the SDGs, WHO, UNICEF, UNFPA, the World Bank, each of these organisations really led a major report on the importance of adolescent health. And within these reports, as in our Lancet Commission on Adolescent Health, adolescence was being framed very differently, no longer seen as a brief period of turmoil, but rather appreciated as a profound period of human growth and development in which the assets and capabilities that underpin future adult health and wellbeing, social relationships, parenting and employment are established. Very different way of looking at adolescence. Within the Lancet Commission on Adolescent Health that we published in 2016, we framed this notion of the triple dividend that comes from investing in adolescence. So during adolescence itself, so for example, with fewer deaths from accidents and injuries, the most common cause of death in young people. Benefits in adulthood as young people mature healthier with, for example, fewer NCDs, that non-communicable diseases that I'll talk about a bit later. And then for the next generation. And it's this intergenerational benefit that I think has been particularly neglected. Peter Sheehan from Victoria and his group reviewed the investments for UNFPA and demonstrated benefit cost ratios of 10 for a range of investments in adolescent health. That is, that for every dollar spent, there was a tenfold return on that investment. And Marion, you might be interested to know that that includes the benefits of HPV immunisation for adolescents. Interesting, we're at peak youth. Changing demographic profiles mean that the world's 1.8 million 10 to 24-year-olds, the largest cohort of young people that we are likely to see. And the question for national governments is whether they're going to be able to reap the potential demographic dividend that comes if they can educate and particularly employ young people, or whether those countries are going to fall off what's been called the demographic cliff when they can't achieve either. And so it's interesting to think about which countries have got both the biggest number of adolescents or the biggest population proportion of adolescents. So the region of the world with the biggest numbers of adolescents are Sub-Saharan Africa and South Asia. But the countries in the world that have got the largest population proportion are very much countries in our region. During the pandemic, it's interesting that we've all learnt that, or I've certainly learnt that Italy's got one of the oldest populations in Europe, and their median age of the population is 47. That is that in Italy, 50% of the population is older than 47 and 50% is younger. In Australia, our median population age is 37. And in our region, in Indonesia, it's 29, virtually 10 years younger. In Papua New Guinea, it's 22. And in the Solomon Islands, it's 19. So many countries in our region have extremely high population proportions of young people. And in PNG and the Solomons, it's about a third of the population is in that 10 to 24-year-old band. But in many of these countries, the challenge is that whilst they may have developed very strong expertise in maternal and child health, particularly over the MDG era, whether it's clinically or in terms of public policy, and indeed in terms of accountability and reporting frameworks globally, in too many countries there's a major lack of technical expertise when it comes to adolescents and the health issues they face, whether from communicable diseases, non-communicable diseases, or indeed from accidents and injuries. So what are some of the things we need to think about? For adolescents, families continue to be as critical a resource as they are for young children, but increasing age across childhood and adolescence brings very different opportunities, particularly around the importance of schooling. Now, I think many of you will appreciate that there is clear evidence of multiple benefits of education for health, and the benefits are that there are benefits of, if you like, lower secondary education over upper primary, and also benefits for those students who continue to upper secondary over lower secondary, especially for girls. And obviously last year over the pandemic, school closures affected over 90% of the world's students. And by April last year, it was estimated that close to 1.6 billion children and youth were out of school with huge concerns about their lack of access to nutritional programs for about 365 million children and adolescents. It's thought that that's their primary meal is at school. Concerns about exposure to greater domestic violence in families' homes with greater risk of substance use by families and risks of early marriage as a consequence of poverty from the pandemic. And whilst I think we can appreciate that children and young people are less directly influenced by the pandemic in terms of health risks, the knock-on or indirect effects of the pandemic are being increasingly realised as, despite schools reopening now in many countries, including obviously Australia, many young people are now appreciated to have failed to return to school. And for those who have returned to school, their mental health burden is high. And certainly in high-income countries, the only countries largely where we do have data available, there are now a number of really good time trend studies that have tracked common mental disorders in different ages and have consistently shown that it's the older adolescent and young adult population that have got the highest rates of anxiety and depression of any age group in the population. And so whilst we've long appreciated the benefits of, if you like, education for health, suddenly now there is the penny dropping in the community of the benefits of health for education, as too many young people with mental health conditions are either not attending school or are attending school but not being in the strongest position to benefit from the learning that's available to them. So I just want to speak briefly about non-communicable diseases in adolescence, because we all appreciate, I think, that the extent that adolescence is this highly dynamic period for the onset of what we think of as NCD risk factors for later disease in adolescence. And I always use the example of tobacco as this archetypal risk factor for adult NCDs. If you don't start smoking as an adolescent or a young adult, you won't smoke in later life. And we see very consistent patterns around other concerns like overweight and patterns of physical activity, forms of substance use as well, and early onset of sexual health risks. We know that young who are on what I think of as the fast track to adulthood, who leave school earlier, who are more socially disadvantaged, have much earlier onset of more severe risk factors for NCD. So earlier onset of sexual activity, again linking to Marion's presentation, is a greater risk for HPV infection and cervical cancer in later adult life. But I think what's been also neglected is that young people experience NCDs during their adolescence. So I've mentioned mental disorders, and we know that 75% of adult mental disorder has its onset either in childhood or before the ages of 24. And this is, together with chronic physical conditions or non-communicable diseases, the largest single NCD in adolescence. But there are many other NCDs that are in the same groupings as adult NCDs, so cardiac disease, but from a very different nature. So in adults, it's coronary artery disease, with obesity and tobacco being major risk factors. But in adolescents, certainly in our region, it's rheumatic heart disease, which is the major NCD in the cardiology area, or survivors of congenital heart disease, where, if you like, those notions of secondary prevention when we typically think about NCD prevention don't cut it. It's a completely different set of risk factors. So I think one of the things we need to appreciate is that we need to be thinking better about primary risk factors for NCD prevention, which occur largely in childhood and adolescence, versus the secondary risk factors for NCDs around people with, say, type 2 diabetes, who are overweight or obese, needing to lose weight. And I suppose just that final comment that we know that young people who do have NCDs need access to healthcare, but for whatever condition we face, but particularly for stigmatised, sensitive conditions, whether we're talking about mental health or sexual health, the barriers to young people accessing quality health services are much greater than for any other age group in the population. I wanted to mention the importance of schools and health, as I've talked about just earlier, but to just bring to your attention some new WHO resources that are going to be published next month. One is around the first ever global standards on what's called health promoting schools. So this is looking at the notion of schools not just as a platform for the delivery of specific health programs or interventions, whether that's school meals or a sexual health curriculum, but rather looking at schools as a community by which the relationships between students and their peers, between students and teachers in that social and physical environment of schools provides a context for good health or for poor health. One of those global standards, number 8, is around school health services. And there's also a new school health services guideline that WHO is going to be producing next month as well. And so they will soon be on the WHO website. Finally, a word about partnerships and the SDGs. Now, well appreciated that adolescents were neglected in the MDGs, which is no longer the case in the SDGs, although we don't have as robust an accountability framework as we need. I think we could appreciate perhaps that when we think about the array of health issues that young people experience, that adolescents risk being everywhere and nowhere. Everywhere in the sense that they've got so many complex health issues that they're sort of everyone's business, but nowhere in terms of accountability and responsibility. It is pleasing to see much closer collaboration than previously within the various or between the various UN agencies, particularly UNICEF and WHO. And it's also pleasing that more is pleasing that there is greater recognition of how much more national governments are needing to invest in adolescent health. And I particularly also want to just bring to your attention, it's a little way off now, but in 2023 there's going to be hopefully a UN summit really looking at driving national investment by governments more in adolescent health with a focus on adolescent wellbeing. But my final word is really about young people and the partnerships that we also really need to be developing with young people to equip them with the voices that they have and are needing to be supported to have more, to be able to speak to the health issues, the life issues, the wellbeing challenges that they experience in their communities. And that requires us as adults in communities to really learn how to better engage with young people, work around notions of co-design, and really not just provide a seat at the table for young people, but in many cases to give up our own seats at the table in preference to them. Thank you very much.
Thank you very much, Susan. So we'll now hear from Professor Tony Capon. Tony directs the Monash Sustainable Development Institute and holds a chair in planetary health in the School of Public Health and Preventive Medicine at Monash University. He was a member of the Rockefeller Foundation Lancet Commission on Planetary Health. A public health physician, Tony's research focuses on urbanization, sustainable development, and human health. His career spans the local as Director of Public Health and Medical Officer of Health in Western Sydney to the global as Director of the International Institute for Global Health at the United Nations University. Tony currently co-chairs the Future Earth Health Knowledge Action Network. Welcome, Tony.
Thanks very much, Barbara, and thanks also for those terrific opening presentations. I guess what I thought I'd focus on is to broaden out and think about, if you like, the nexus between human health and the other sustainable development goals, because while Goal 3 is very much focused on human health outcomes, all of the other 16 goals relate to human health and well-being in different ways. In global health, we talk about determinants of health. So whether these are social determinants, economic, or environmental determinants of health, they're picked up across all those other 16 SDGs. And as has been pointed out earlier, of course, in the last year or so, we've been very focused, rightly so, on controlling the COVID-19 pandemic. And perhaps that means we've neglected these other important issues that have been referred to already. And so as we look ahead, as we recover from the pandemic, I guess a big challenge for us, how might we deliver, if you like, a healthy, fair and low carbon recovery? Because one of the biggest issues, of course, that we confront collectively around the world is climate change. And climate change is a health issue. We know that climate change is already affecting the health of Australians, the health of people in our region, the health of people around the world. Now, the pandemic and our efforts to control the pandemic have certainly exposed the deep inequalities in Australia and around the world. We've also learned that we can make abrupt, very substantial change, and notably that our policymakers, our elected officials, can take heed of science and evidence, particularly, of course, health evidence. And so we have to try and maintain that momentum as we invest to recover from the pandemic. And as you know, we're investing trillions of dollars around the world. How can we get the best bang from the buck? Our ambition should be to build back in ways that accelerate transitions to sustainable development, in ways that are healthy and fair, in ways that deliver the whole 17 SDGs. And when we put the NCD lens on, in essence, what I'm talking about is addressing what we call the causes of NCDs. For example, tackling what's behind air pollution, addressing sedentary ways of living, addressing unhealthy diets. If you like, it's about rethinking the way we feed, move, house, power, and care for people, no matter where they live around the world. Importantly as well, we know much of what needs to be done. It's very much about getting on with it, applying that knowledge, and continuing to learn as we go from an implementation point of view. Whether we talk about energy systems, for example, accelerating transitions to renewable energy, which will reduce carbon emissions, of course, but will also reduce toxic emissions and improve health in places like the Latrobe Valley or the Hunter Valley here in Australia or in countries across our region. Making sure also that this transition is a just transition. What are the new livelihoods for people in the Latrobe Valley, in the Hunter Valley, in parts of the world where people rely on coal to make a living? How do we plan for new livelihoods? Agri-food systems have been mentioned already in this session. We need to transition to regenerative agricultural practices, at the same time improving food quality and the diversity of the food we eat. Cities, as well, as Barbara said, an area that I focus on in my own research, building healthy and sustainable cities, enabling active living in our cities. For example, we learned a lot about cities through the pandemic. Air pollution levels down very significantly in Melbourne, for example, because there was less commuter travel. So how do we benefit from what we've learned and really look ahead to deliver this in the long term? What needs to stick? And finally, reflecting on our own our own patch, getting our own house in order as health workers. How do we reduce the environmental footprint of healthcare? We know that 7% of all Australian carbon emissions are attributable to the work of the healthcare system. And we've also seen the personal protective equipment that was used to prevent cases of COVID-19, lots of plastic gowns, lots of masks. We see them on the streets, in the parks, and they're affecting many other species, not just the human species, all of that waste. So we really need to do better in this area and get our own house in order as healthcare workers. So the final thing to mention, and I'll just put it in the chat box in a moment, Barbara, is the World Health Organization's manifesto for a healthy recovery from COVID-19. Picks up many of these issues that I've been speaking to, published and promulgated almost a year ago now, and really sets out a path forward. So back to you, Barbara.
All right, thank you very much, Tony. So that concludes from our scheduled speakers, and I think we move on at this point to what I hope will be a very lively chat session. And I can see that we already have a couple of questions, which is excellent. I think that I'll start off by asking them both and allowing you to pick up what you would like from both of them. So the first one comes from Ian Howie. Hi, Ian. Who points out that the failed target in the Millennium Development Goals was maternal mortality, and he was interested in whether anyone can comment on progress in that area under the SDGs. And then the second question was something I also had in mind, which is that Tony has really said a lot about how we might capitalise on the post-COVID-19 moment in terms of the implications for resetting the various paths, including in relation to climate change and NCDs. And clearly, the events of the last 15 months are going to remain impacting the world for the foreseeable future. Abby Minter asks, to what extent does that mean that we need to revisit the Sustainable Development Goals as they relate to the NCDs? Do they need to be revisited? Are they still achievable? How does COVID-19 impact our thinking? And perhaps I'll start with Marion and then Susan, on the basis that you hadn't said so much already about COVID-19. And if any of you are able to comment on the SDGs and maternal mortality, please do as well. So, thank you. Marion. Are you mute, Marion? I can't hear you. Perhaps we go to Susan first and then go to Marion, so she's time to sort her audio out. Susan, would you like to comment on that?
I think in relationship to thinking about resetting targets around SDGs, I think the trouble we've got, Barbara, is probably we've got a time delay. So I might pause and let
I can hear you fine. I imagine the...
Okay. I think in terms of resetting targets, I think it's premature for that, but I think that certainly what it does tell us about, as the point that I would make, is about the importance of data and being nimble with data in terms of being able to understand changes over time and just in order to be able to then think about how best we might respond. And in terms of, I gave the example of mental health, for example, and the particular problem in adolescence is that the reason that I didn't say anything about mental health in our region is that we have remarkably poor data about mental health around young people in our region, and that's the case for a whole lot of adolescent health issues. And so I think I would say that in terms of some of these NCD and SDG targets, I really think that we have to think seriously about what are our data monitoring systems and getting them right. Perhaps the final thing I would say, it's not so much in terms of trends in maternal mortality. I take Ian's point that the MDG goal had been a reduction of 75%. We achieved 44%, which was good, but certainly not good enough. But the concerns are that in relationship to access to unsafe abortion, access to contraception, that this is only going to be made worse during the COVID crisis in terms of reduced access to health services.
Thank you. Marion, are you able to?
Yes, can you hear me now, Barbara?
Brilliant, thank you.
Look, I'm not an expert in sustainable development goals. I'm a very focused person around the cervix cancer prevention. But what I would say is that I'm hearing from colleagues that good progress is being made in the maternal mortality space. And as they put their heads up from that, the next big problem for mid-aged women is cervix cancer in low and middle income countries. We're talking about the sort of prevalence that would be close to the prevalence we have of breast cancer here in Australia. And that means in those countries, everyone knows someone who's had or probably died of this cancer with a great deal of shame. So I think as we solve some problems, others come into focus. What I would say is that the goal around reducing deaths due to NCDs can be significantly contributed to by preventing cervix cancer. And unlike other NCDs where you have to be healthy all the time, you have to breathe clean air for years and years and years, with cancer prevention through screening, and particularly with these high precision tests, we're talking about interventions we need to do once or twice in a lifetime. And so in that sense, they're low-hanging fruit to head off a cancer that has such devastating impacts. So, and I just want to follow up on a comment Susan made, which is monitoring and evaluation. And this is something we're particularly good at in high-income countries from our PAP programs. I mean, Australia's had PAP test registers for decades. The first one was actually established in Victoria about 30 years ago. We know who's getting screened. We know who's not getting screened. We're starting to understand the characteristics of those groups. We've got a framework for evaluating what we do to make a difference. We know whether people are getting followed up after their abnormalities. And actually, the other thing those platforms do is they help us follow up those people and drive them to assessment and, where necessary, treatment. So I really support the idea that, and certainly cervical cancer prevention in Australia shows how important it is to have data systems that tell you what's happening and can help guide public health interventions to optimise program delivery.
And Marion, are those data platforms helping people to see what the impact of the last 15 months might have been on either HPV vaccination, screening levels, or indeed treatment levels of people who have symptoms?
Absolutely. So the National Cancer Screening Register records every cancer screen across Australia unless the screen person opts out, and that's almost all of it. And there is information about what has happened to screening rates through the pandemic. The Australian Immunisation Register, of course, collects data about all immunisation, including HPV vaccination in Australia, and similarly will be able to tell us, provided we can access the data, what's going on there.
And outside Australia and the rest of the region, do you have are there good data sources for that? Or
around the region, I think it's an area that we work in from VCS. So part of the funding from Minderoo will be to establish a cervical cancer prevention register for Papua New Guinea, Western Highlands and Vanuatu. We're using an Azure-based solution that we've developed that we think we can customise to countries in partnership with what the countries want and how they want to run it. But, there's a bit of a challenge with the very small island nations of the Pacific. And I think there's always been challenges in trying in a range of health sectors and trying to have them share infrastructure like this. It's a bit hard to justify for a very small country, but it might be possible across the Western Pacific to have a platform that brought together those small island nations who do have a very high burden of cervix cancer.
Tony, any further comments from what you'd said earlier in relation to those two questions?
Yeah, I guess the main thing I'd like to add is that perhaps picking up on some of the things said earlier by Susan as we look back to the MDGs and the progress we made there, and as health workers, the MDGs, of course, quite a few of them were very specific health outcomes, whereas the SDGs is a whole different way of thinking about development. It's about an integrative approach to poverty eradication and sustainable development. And that means that as health workers, we have to, I guess, reflect on how we engage with this kind of goal setting in development practice, because the point I made earlier that when we're thinking about whether it's adolescent health or maternal and child health, thinking about what are the relevant other SDGs apart from SDG 3 that we should pay attention to, and recognizing that these are all determinants of health in those other SDGs, and in the end shape the living conditions of people in Australia and around the world. And so I think it's good if we can all kind of reflect on our practice and think, are there new people we should be talking to? Are there new connections we should be making, so that we're really able to address these causes of health problems? And I think the SDGs can help us with that.
Thank you. And Abby's asking another question related, specifically picking up on some of the questions about data that are starting to be raised, pointing out that we're getting, excellent data on COVID, daily updates on cases and mortality rates from around the world, and yet we don't seem to be able to do the same for other conditions. And I think I might just broaden that question out as to why is it that when we have an acute infectious disease problem, we seem to be able to marshal resources, marshal concern, really pull the stops out in ways that Tony was describing in terms of responding. And yet we all know that the pandemic of non-communicable diseases has been a global disaster for some decades. And yet we just don't seem to be able to get the same level of concern, interest, resources mobilized. So, Marion, I'll go back to you and see if you have any comments on that. You've got a very long experience of advocating for more attention to cervical cancer, which I'm sure is a case in point. What would your comments be about why we jump with one scenario and we sweep through the other?
Well, I would say in Australia we've been well served by, in a bipartisan way across the decades I've been working in cervical cancer prevention. So the screening and vaccination programs have been well funded. Australia was the first country in the world to put HPV vaccination onto its national schedule. We still have challenges in relation to equity. And when we moved across from Pap smears to HPV tests, the biggest barrier was the status quo and professionals not wanting to change practice. So I think, never waste a crisis, right? I'm a pathologist. I was never allowed to release a result to a person. Always had to go through the ordering practitioner because that relationship was sacrosanct. It started to feel in the later years quite patronising. But all of a sudden now, the way we work in Malaysia is we send the results, and we did this before the pandemic, to the woman's mobile telephone number with her permission by text message. We also use that as a touch point to find her if she didn't come for follow-up. I think there's now the opportunity. The opportunity is that this crisis overcomes some of the professional barriers and says, actually people can handle their own information if that's what they want, and we can do things differently. So, look, I think the challenge of funding for cervical cancer prevention is in the low and middle income countries, is trying to get affordable tests in the way we get affordable vaccines through Gavi. There's no similar mechanism for bulk purchase of the HPV tests. That's a bit of an issue. And of course, it's still very challenging to get HPV vaccination into countries in the region, partly because of a global manufacture supply that no doubt will be made worse by the COVID pandemic, but also just plain old-fashioned affordability and a lack of will. So more challenges with COVID, a couple of opportunities, and of course, self-collection offers us the opportunity to continue to have women engaged in screening in a socially distant way, which you couldn't, of course, with the old-fashioned speculum exam.
Thank you, Marion. Susan, perhaps you could address this particularly with reference to the region as a whole, because I think Australia obviously is responding better on the NCD on the NCD side than many of the other countries in the region, and devoting more resources than they're able to. But I think perhaps thinking particularly about UN partnerships, how can we move the temperature up in terms of reactions to and responses to NCDs?
Look, I think, and I had noted one of the other questions also about technological resources. I'd go back to the fact that we're not sufficiently monitoring in timely ways the sorts of NCDs and risk factors which could help generate the sort of urgency and responses in individual countries, certainly in our region. And I would argue that we're not particularly good in different population groups in Australia as well. But I think in terms of NCDs, I think there are also some really exciting opportunities that have come out of the pandemic. So the shift to telehealth, for example, that has been forced on so many people. And certainly, I'm a late adopter of telehealth at the Children's Hospital, only using it previously when I was forced to in terms of country-based patients. But now, see a lot of my patients using telehealth, as so many health professionals are doing. And I think in a similar way, that has, a bit like Marion's comment, I think it's, democratised access to healthcare. It's made direct access and those historical barriers much easier, notwithstanding that obviously access to 3G networks, health literacy to negotiate the technical platforms, all of those equity challenges are still very much there on telehealth. And I was just in a meeting this morning reviewing cancer outcomes across the Victorian population and appreciating the devastating modelled reduction using cancer registry data overall, but the reductions in the presentations of people with cancer to services that are perhaps reflecting not just the individual fears, but lack of access to routine screening across the pandemic as well. So telehealth, an important solution, but by no means a miracle solution. But again, I think in terms of access to specialist expertise for small populations that don't have ready access to specialists country by country, I think there are some different ways of thinking about working creatively with local health professionals, potentially teleconferencing with more disease-oriented specialists who are geographically distant.
Thanks. Tony, any further thoughts on these questions?
Yeah, I was just reflecting that yet absolutely we seem to be better at, much better at COVID-19 surveillance than we are at NCDs. But I think it's important to remember that we're not good at all infectious diseases. The neglected infectious diseases we're not so great at. And I think we have to reflect on what might be the reason for that, and it's at least partly because of who's affected by these diseases. So COVID-19 affects wealthy people in the world as well as poor people. So, if you're a wealthy person in Sydney or Melbourne or in London or New York in the early phases of this pandemic, you were actually a bit at risk because you're often hypermobile, often in ski resorts, for example, where some of that early transmission happened. So I think while COVID-19 is a health issue for everybody in the world, it's at least partly because it's a health issue for rich people that has meant that we got on top of it much faster than we do many of these other big health problems.
Thank you, Tony. There's a very interesting question here from Isabella Allen. And she's asking, how are the panelists addressing Indigenous people's rights to their data when establishing registers and so on? And I think, Marion, that might be, first of all, a question for you, because I think it's you that's been talking about registers that you guys are using or managing. I wonder if you have any comments on that, first of all.
Well, actually, the issue in Australia in relation to cervical cancer is that Aboriginal women are twice as likely to contract this cancer and almost 4 times as likely to die of it. And we have not been able to persuade all the actors in the system to take this seriously and to ensure that we have proper identification of Aboriginality, and we identified Torres Strait Islander people participating in the program. The work I've been involved with has been with Aboriginal organisations, and they are concerned to have that data in there so that we can look at more than just the outcomes, but the processes and where we're failing. We know in some jurisdictions that the screening programs are not meeting the needs of Aboriginal women, and therefore they're not screening as often. We also suspect but cannot prove that there's a bit of a barrier between screening, assessment, treatment, and where there's a diagnosis of cancer, getting to treatment early enough so that the cancer outcomes, once diagnosed, are poorer. So interestingly, all people can opt out of cancer screening registers in the Australian context and don't need to be in there if they don't want to. One of the protections is that no data can be analysed by Aboriginal or Torres Strait Islander status without community input and approval. So there's an individual right to have your data not included, and there's a community expectation of being involved in analyses that are productive, helpful, and lead to better outcomes.
Thank you very much. I think probably that's the answer that was being looked for across the board. I don't think I'll pass to Susan and Tony on that one. We are just beginning to run out of time, and I thought that I would just ask each of the presenters if they would like to wrap up with a key message, a key suggestion for 1 or 2 critical steps that need to be taken over the next couple of years to move forward on these issues. And Tony, I'll start with you as we finished with you before.
Yeah, well, thanks very much, Barbara. And I think we must remain positive that, the enormous disruption that we've had from the pandemic and notably from the measures we put in place to control the pandemic have had enormous impacts around the world. And I think in particular, Susan, for young people have borne the burden of this in the interests to a large extent of the health and well-being of older people in society. And I think we really must acknowledge that, and we really must support young people now. And it's a responsibility for older people in society to stop focusing on their own needs and start thinking more about younger people. And I guess, frankly, I would point to taxation issues in our country, for example. The fact that we've got some very noisy older people concerned about their superannuation accounts. I think we have to get real and be much more concerned about the well-being of young Australians and young people around the world, and be more generous as older people in society to young people. Be less critical of young people. I mean, I must admit the generalizations about the millennials that I hear it's cringeworthy stuff. And we've really got to rethink that. So that would be my final point, Barbara.
Thanks, Tony. That's a great lead in to you, Susan. Would you agree?
I couldn't have, I think you've said it way better than me, Tony, but I couldn't agree more in terms of this. I mean, if there's one thing that I would do, would be trying to get the vote reduced in age from 18 down to younger age groups, because as you've signalled, young people are ignored by our political class. They don't have a voice, and one of the reasons is that they don't have a vote. And so I think that empowering young people, as social media is, one mechanism of empowering media, but I think we really owe it to young people to do a better job. I suppose my sense is that it's really reflecting on those comments before about why might we be able to pay attention to COVID-19 in ways that we can't about some of the bigger health challenges. And Tony, I'd like to throw it back to the existential challenge of climate change, and recognising again that young people are inheriting not just the health of the past generations, but also the world that we leave them, and the responsibility that we have to equip them with the skills and resources to do better than past generations have done, I think are a huge responsibility. Thinking about educational investments, I think, therefore, thinking about the roles of schools, rethinking the very context of education, from sitting in classrooms and being brought out of our brains to doing something very differently, is a really, really challenging opportunity that's been really, I think, thrown up and highlighted during the pandemic.
Thanks, Susan. Let me turn finally to Marion on the same question, but also, Marion, if you wanted to pick up on Isabella's further follow-up question about data from PNG and Vanuatu, do feel free to do so. But let me just ask you to have the final word.
I can't see the questions, but I will say that as part of this project, we will be creating a register that will be secure, that will enable us, we hope, to keep in contact with screen-positive people, also to record vaccinations, and to provide de-identified data through to the researchers who will evaluate the effectiveness of the triple intervention strategy that WHO has agreed on in a motion that was sponsored by Australia at the last World Health Assembly, actually. And I guess I'll finish by saying that, I've got a 17 and a 20-year-old daughters, so I've been listening to what Susan has said with interest and some insight. They've been vaccinated. I don't think this cancer will be part of their future. I think some of the things you're talking about will be part of their future. But for their counterparts in the region, that's not the case. And I guess I'll finish on a note of optimism, which is to say that I haven't been deeply involved in the global health arena, the targets, and so on. But I think what I have seen with the targets for 2030 to put countries on the pathway to elimination of cervical cancer as a public health problem is, after a couple of years of going to meetings in countries and going around in circles, I really do think that these targets have created a great degree of alignment, and I feel like we're making forward progress with what needs to be done in partnership with countries to really, really help them with this issue, which, as I said, it's a once or twice in a lifetime strategy. It's not something that has to be done all the time, and in some ways it's quite achievable, and I think it gives the stakeholders in country a sense that this is something they can do quite soon, quite well, and I know the other NCDs are much more challenging because of the behaviour change you have to affect, over decades of lifetime. So I think targets can align people. So that's my finishing note of optimism.
Thank you very much, Marion. And that brings us to the end of the session. Thanks to all the speakers and thanks to the organisers and to all the participants and those who asked questions. Delegates, you now have the opportunity to take a small break. Please join us again at 3:30 for the plenary session, which is partnering with the UN and International Focus. Thank you and see you soon.